All right. Hi, everyone. As I said, I'm Heather Brandt with the St. Jude Children's Research Hospital. I direct the HPV cancer prevention program there, and I've been tasked with talking about rural HPV vaccination. So we just had the opportunity to hear some of the quiz questions and answers, and it sounds like most of this room, or at least 3/4 of this room, is very familiar with the reason why we would want to take a look at rural HPV vaccination. So the reason for this focus is because we find low HPV vaccination coverage universally in rural areas, and we see higher incidence and mortality of HPV cancers in those same regions. And so for that reason, it's important to identify how we can address these barriers that exist and capitalize on what does exist, because 20% of the US population lives in rural areas. So 1 out of 5 people live there. And many of you know that I'm originally from Iowa, and so rural living is how I was raised, and it's certainly where many of my family members live today. And just by virtue of living in a rural area, doesn't mean someone should be at higher risk for developing these HPV cancers. And so there's something we can do about it. It's also important to note that rural experiences and rural life look very different. It's a very diverse group of people who live in rural areas. So rural communities are not monolithic, and rural approaches are not one size fits all. So let's take a look here at the HPV vaccination data over the period of 2018 to 2022. We clearly see that there are 10 percentage points difference between our rural, so those living in a non-MSA, and those living in an MSA principal city. And vaccination coverage has consistently been lower for adolescents in rural areas for some time. But while these deficits remain, just as we've seen NIS teen data trends over time increase for the whole population, there have been increases in coverage among rural adolescents. So recently in our program at St. Jude, we convened a group of rural parents and grandparents to learn directly from them about why they prefer living in rural settings, why they think some people in rural settings are not getting vaccinated, and what can we do to improve those. So earlier you heard Dr. Paskett talk about some of the barriers that are longstanding in rural communities, and some of those are definitely reflected here. And so we can see that they trust healthcare providers. So how can we ensure in rural areas that healthcare providers are a conduit to making strong recommendations for HPV vaccination? We know that with this era and age of misinformation and disinformation, and the way that those myths and misconceptions are shared, it offers us an opportunity to return to a trusted source. And so healthcare providers were certainly identified by our panel of rural parents and grandparents as an important conduit to improvement. I included this quote on here from one of our rural parents. Many people that I consider friends will elect not to get their children vaccinated for HPV because it's not required, they think it will cause infertility, or it will encourage sexual activity. And these are very common barriers that we hear from rural parents and caregivers. And so lastly, I'm excited to have the opportunity to share this information with you about rural HPV vaccination and give you some information about some of the work we're doing at St. Jude to take on this challenge with the National HPV Vaccination Roundtable and the American Cancer Society. And I hope if you're interested in improving HPV cancer prevention for 20% of our neighbors, that you will join our efforts. And there's more information up here about how to do that. Thank you.
Okay. Hey, everybody. First, I just want to thank you all for making space to talk about LGBTQ equity today. It's really important to me personally, and I think to medicine as a whole as we move forward. So a little bit about me. I'm Amy Weiser. I use she, her pronouns, and I'm a full-scope family physician from Portland, Oregon. I started out my career in rural medicine, moved into academia, and now work for urban underserved. I work for Cascade AIDS Project at Prism Health. Prism is a lookalike FQHC primary care clinic, and we focus on the health of our LGBT community as well as our HIV community in Portland, Oregon. So because nothing in this format can be out of line, I decided that I wanted to share a story with you all about a patient by the name of Janessa, and also her journey to the speculum. So this is a new patient of mine. She presents to the office to establish care. And I said, you're a new patient because I also want you to think about this from a conversational perspective for what I'm going to present. So Janessa is a lovely 37-year-old cis woman, uses she, her pronouns. And she comes to me and says, you know, I'm in medicine too. I'm a medical assistant at an FQHC in a rural community just in the next town over. And code for that is the next town over is about 45 minutes away. So I thank her for taking the time to care about her own health. Moving into the medical history, she reveals that she has some depression, anxiety, and she takes some Lexapro and then says, yeah, Amy, because it's 2023. Moving on in her history, overall, she's pretty healthy. We talk about her social history, kind of run-of-the-mill stuff, and then we move into her sexual history. And she says, you know, I've never had any STIs. I congratulate her on that. She says, you know, I've never had an HPV vaccination, but I'm kind of interested in this. Can we talk about it a little bit? And I said, absolutely. And then my next question to her was, you know, thinking about preventative health, when was your last cervical cancer screening and what were the results? And I asked her this question and she looked at me. She had this really funny look on her face, which made me think that maybe I said something wrong. Like I asked her colorectal instead of cervical. And she said, never. I've never had a cervical cancer screen. And so at that moment, I stopped doing my charting and I faced her directly because I wanted to engage and lean into this a little bit. So what I asked her and what I haven't told you yet is how she answered the question about her sexual orientation. And sexual orientation and gender identity are really important things to ask. Because if you don't know the person in front of you, it's really challenging to care for them in the most optimal way. So we leaned into this a bit, and this is what she shared. She said, I'm a lesbian, and I've only ever had cis women sexual partners. My family doesn't know this. My work environment doesn't know this. She never outed herself because she was concerned about ramifications on cultural status, on community standing, as well as her professional career. So she said, you know, I'm not sure what I have to gain, but I know I have a lot to lose. And next thing she shared is that she's never needed to be, and she's never been on any birth control. She said, there's no sperm in the vicinity, so I've never really needed to pursue this. Fair. She also shared in her sexual history that she doesn't have penetrative sex. Now, because of those two things, she understood that she wasn't indicated to have a cervical cancer screen. She's never had a speculum exam. And so when I started to explain, you know, why we screen, who we screen, and how we screen, her eyes got really big and you could feel the anxiety just blossom because we were covering something that surprised her and that made her really overwhelmed. The last thing she said to me was that, you know, I'm coming to you 45 minutes away because my town is really small and not super LGBTQ friendly. And so I have a lot of limits as to where I can go and get my medical care and feel comfortable and feel like my provider will be able to see me for me and I can trust them. So in this short conversation, several themes have emerged: discrimination and access or lack thereof. Unfortunately, these are not new themes within the LGBT community, deep-rooted in history and even still today. But the offshoots of these lead to misunderstanding, misinformation, and knowledge deficits. These impact patient care, why they come, who they come to see, and what they expect. But providers also need to understand this in order to care for our patients. Now, the last thing I'm going to say is that this isn't Janasa. This is my medical assistant who allowed me to share her photo with you today. And these are some really great folks that I have the opportunity to work with. And I bring this up because you may think that this might be a one-off story, and it's not. And these fine people shared their lived experiences with me when they knew that I was coming to share this with you. So there is a high level of authenticity in the story that I shared today. I'm also very thankful to have these fierce advocates in the community ensuring and promoting HPV vaccination and cervical cancer screening. Thank you.
All right, so I'm Caleb Levell. You might know me as Wilson in off-Broadway HPV vaccination plays. And I'm going to be really, really brief because I think, one, Ashley is the one that you really need to hear from because she's been really the lead on this project and has done such a fantastic job for our roundtables. And two, you've had just two really, really great presentations that I know you guys are wanting to dive into conversation. So we get an opportunity to share, so I should say my actual role instead of Wilson is I'm the Strategic Director of National Roundtables at the American Cancer Society. So I have this really cool job where I actually get to come and meet all of you at all the different roundtables and think about ways that we can coordinate across roundtables, make them more efficient, learn from each other, take all the good stuff that you all are doing here, take it to the colorectal cancer roundtable, lung cancer roundtable, navigation, et cetera. So one of the things that we've been doing with our roundtables to talk about efficiencies and where we can improve performance or really share best practices and lessons learned is in the health equity space. So this actually started back in, the middle of 22. We actually started having conversations. Can we get our roundtable teams together to address health equity, think about what their roundtables are doing with health equity issues, and can we learn from each other? And we brought on the health equity team at ECS to really help us think this through and think about what maybe be some deliverables, some tangibles that we can come up with to do that. And Ashley's gonna share that with you. I will say that what actually an interesting thing is our organizational restructure happened, I think, on February 8th of 23. And that was the day that the roundtables were all together meeting for the first time on these health equity issues in person in Washington, D.C. So I can say that our very first thing as a business unit that we did together was talk about health equity. It was just really kind of a nice coincidence for us all to be together at that time to really dive into this issue. So the goal of the particular program was for the health equity team to work with us, our roundtables teams, to support the ACS roundtables by providing a space for roundtable teams to learn more about health equity, develop roundtable-specific health equity action plans, and again, share other health equity best practices, the challenges, the successes. And I know the HPV vaccination team has done a really great job of engaging their leadership to look through these action plans. I know the cervical cancer team has really been engaging leadership and their members to look at their health equity statement. So I appreciate all of your time kind of tackling this with us and how we can address it. And then at the end of 2023, we really have these action plans that we've actually effectively worked on. We've done 2 to 3 of these things that we wanted to do and kind of improve what we think our own kind of professional experiences are and our own confidence in this basis of health equity. So you can kind of see the timeline here. I don't need to really dive into it too much, but again, you can kind of see this is a conversation that we've really been very thoughtful about and revisiting and continuing to grow and learn as time has gone on. And I think with that, I can let Ashley start to share the details.
All right, good afternoon, everyone. Yeah, I want to see if you're awake still, please. I know it's the post-lunch slump. My name is Ashley Brown. I'm the Strategic Director of Health Equity at the American Cancer Society. So as Caleb said, our team has been working with the roundtables for the past year to be really intentional about integrating health equity into the roundtables. But before we jumped into the roundtables, we really wanted to talk about what health equity means to the American Cancer Society. So to ACS, health equity means that everyone, so that means no matter the color of your skin, your sexual orientation, your gender identity, no matter where you live, that everyone should have a fair and just opportunity to prevent, find, treat, and survive cancer, right? So we had our own health equity definition because I'm sure you've seen many health equity definitions, but it was really important for us to kind of tailor the definition through the cancer lens. And as part of this work, this defining health equity work, we said we can't just have a definition, right? We really needed to make sure that everyone at ACS, our volunteers and our partners, understood what health equity is and how to practice health equity. How do you put this work into action? So we developed these health equity principles. That's the wheel you're seeing on the screen. The first step was to make health equity a strategic priority and then continuously learn and improve. And what we really did was to divide these principles into a framework of people, place, and partnerships. So when you think about people, you think about helping people with the greatest needs. So that means taking a closer look at the data in your community to understand the cancer disparities that exist. When we think about the people in our communities, we're thinking about who is at the table. So prioritizing diversity, equity, and inclusion. Valuing community expertise, those with lived experiences, making sure that they are at the table as well. For place, it's really understanding the context of the communities that you serve. So addressing structural and social determinants of health. When we think about structural determinants of health, we're thinking about poverty. When we talk about the social determinants of health, we're thinking about housing, transportation, access to education. Those things impact our health outcomes. We want to understand the community, social, structural, and community economic context. It's really important for us to really understand the full breadth of the communities that we serve. And implementing sustainable solutions. So we think about the one-off things that we do with communities sometimes. We ask for their help and then sometimes we leave. But you want to make sure that the relationships you're building with communities are authentic and long-term and that you're building sustainable solutions that they have an input on. And when we talk about partnerships, we talk about leveraging all types of partners, so those outside of the healthcare systems, not just internally within our healthcare system partners, which are great, but making sure as we're addressing some of those social determinants of health, we're thinking about being really creative in who we engage. And then finally, for partnerships, I like to think of this final principle as preventing and addressing unintended consequences, which means do no harm. As you're doing your work, making sure that you're engaging the community at every step of that work, and you're not doing any harm. So these are our health equity principles. We're going to have you do a little activity in a little bit to think a little bit more strategically how you can integrate these in your work. So with the roundtables, we actually tailored our health equity principles to meet their needs. And one of the first things that we wanted to do to make sure that health equity was having that strategic priority was to develop a commitment statement. So we developed within that tool some expertise and some suggestions around how you can develop a commitment statement. The sample commitment statement you're seeing now is from the Cervical Cancer Roundtable, but I think it's really important for everyone to be on the same page when it comes to health equity, because again, there's a million definitions, we all may define it a different way, but if you develop this commitment statement with your partners and you're really intentional about it, and make sure that you're all on the same page. For the valuing community expertise, we really made sure that there was like a deeper dive section around sharing power, decision-making, representation, and accountability. So when you're thinking about building relationships at the community level, you need to think about who is at the table, how are you sharing power with them, how are you making sure that they have an input on the decisions that you're making, and finally, how is everyone accountable to the decisions that you're making? So we included some details about how to be very strategic about that. So our roundtables, as Caleb said, went through this action planning process where they had to, for each of those principles, they had to outline what actions they would take over the past year to make sure that they are being really intentional about health equity. So they had to think about who was leading the work, what was the ultimate goal, and who was driving the work. And all of our roundtables participated in this activity. So finally, I know this is brief, but I know we're trying to catch up on some time today. Finally, I want to leave you with this quote. This is from Dr. Marcela Nunez-Smith. I think when we think of health equity, we think of sometimes the checkbox. What are the things we can do now to achieve this goal, right? But health equity is a journey. I hope that we will achieve it in our lifetimes, but likely we won't. It's a lifelong journey. And for health equity, Dr. Marcela Nunez-Smith says, I think we have to push back on the instinct that the fixes are quick. There is not a checkbox. where we can say, do these 3 things. But it is a process. And if we can do more in partnership, genuinely with communities that have been most affected, that's how we increase trustworthiness.